Okay, after this wonderful lecture by Xavier, I think we are now in the good speed and everybody's at the same line. So now we move to two examples actually. One from Susana Monge, who is from the Spanish Public Health Agency. She is not a part of VAC4U yet, but she has been interested, I think, in these days on what we are doing, focusing very much on effectiveness studies. So she was recommended by Miguel Hernan, who is the master, I think, in this whole framework. So the word is to you, Susana.
Thanks a lot. For those who don't know me, because I'm new to this forum, I'm a tenure scientist at the National Center of Epidemiology in the Institute of Health Carlos III in Madrid. So we were asked to provide some examples on observational studies on vaccine effectiveness, which is my area of work. I never worked on safety. And specifically, I will talk about some studies we did to emulate target trials using electronic health records. I have no conflict of interest. So I will start by saying something that I hope everyone here agrees. Observational research in COVID vaccines is needed. Randomized controlled trials cannot answer every question that we have because efficacy in randomized controlled trials will be very different from what we have in real life, depending on individual person factors, contextual factors, vaccine factors, and very importantly, viral factors. So we've seen the variants of SARS-CoV-2 go evolving over time very quickly. And that has led to challenges that RCTs could not answer on time. So if you remember, how was it on the summer of 2021 in Israel? Israel performs a very rapid vaccination campaign. They started a couple of weeks before Europe, but they purchased a big amount of Pfizer vaccines, so they were able to vaccinate a large part of the population quite quickly. So by this summer, it was already 6 months since they had finished their vaccination campaign. And at the time, a rise in cases was observed, and not only cases, but also severe cases. So they wonder what's going on. One possibility is the effect of vaccines is waning quicker than we expected. It's already 6 months. But more things are going on in this summer. It's the first summer with really low degree of restrictions. There's more economic activity, more travel. Maybe it's just people are getting more exposed. And then the virus has evolved. We have the Delta variant. It came from originated in India and spread throughout the world quite quickly. So there are several things going on. It's difficult to say what's going on. Will it be solved by giving an extra vaccine dose? And what would be the effectiveness against Delta variant? This is nothing that we already saw on a randomized controlled trial. So Israel was faced with a difficult question: make evidence-based decisions or use the precaution principle. And this is always the case. If we want evidence-based decisions, by default, we're behind the evidence. And the evidence may be an epidemic curve with several people dead. So this is a balance that we've been looking for through the beginning of the pandemic. Israel decided on the precaution principle and recommended a booster dose before anyone else in the world did. They did this in the summer, and they were able to perform a very quick study. They closed the study period by the end of September, and in the beginning of October, they had already the first results on effectiveness, and it was only 1 month later already published online on The Lancet. So they were able to show that vaccine effectiveness of this first booster against the Delta variant in the context of widespread social interactions was very high at 93% for admission to hospital, so very close to the initial VE. And that was very important results that allowed the rest of the world to make evidence-based decisions. So it was really a huge effort, very useful for the rest of the world. in a record time. So how was this possible, that less than 1 month after closing the study period, we can have this type of high-quality results, of course, using a randomized controlled trial? So they used electronic health records. This is, very efficient. We're using data that are already there. It's very rapid. The data are being generated in real time, and if the analyst can have the data with the same real time, it's just a matter of days to perform this analysis. Are very representative data sources. They are population level based, very powered, and you may think that in the context of a pandemic this is not important because there's many events. It's not the case, for special populations, immune compromised, children, severe events, deaths. These can become rare at some point, and this data source will be very useful for that. And they're stable, so they allow monitoring over time, and we've been using it like that in several contexts. So what type of electronic health records do we need to perform this type of study? We will need a source of the reference population, so those at risk, because we are going to recreate the cohort of the entire population in our country. We will normally use health insurance databases or residence databases, some source of the vaccination status, and then a source of events and covariates, normally laboratory registries, primary healthcare or hospital registries, death registries, or in some instances, also we can use surveillance data. With this context, I will move to an example of something we did in Spain. And I don't bring this example because it's the best study ever. It has limitations, but I think it's a good example of how with a few data and the appropriate context, we can provide timely results using good methods. So this is the epidemic waves in Spain, and we will focus on here, which is the Omicron wave. You see that the amount of cases, and here the light green is the asymptomatic ones, was higher than ever in the pandemic. The top peak is probably denoting the limit in the detection capacity that we had rather than the total number of cases. And the drop is probably reflecting the end of the systematic testing. So we stopped testing cases at some point because it was unbearable for the health system. So it's not a true epidemic curve, but it gives you an idea of the intensity of the circulation of Omicron. So Omicron became dominant, so more than 90% of all reported cases in Spain on the 3rd January 2022. So what was happening at that time with the vaccines? Here we have the number of doses of vaccines. Green is complete vaccination, and blue is the first booster. So following the results from Israel, thank you, we started recommending a booster dose in the autumn of 2021, and we started by the elderly and the long-term care facilities. So we were slowly progressing down through the groups with the less risk. So by Christmas, when Omicron arrived, and that's the red line here, so this corresponds to when Omicron becomes dominant, we had vaccinated most of the people in the 60 to 69 group, but we were in the middle of the campaign. So most of the doses in the 50 to 59 and 40 to 49 years old were provided actually in a period where Omicron was already dominant. And that provided us with a good opportunity to estimate the effectiveness of these freshly administered boosters in a period where Omicron was already the dominating variant. So we were also able to do this quite quick, so it became dominant in the 3rd January. We closed our study period on 6th February, and we posted the preprint on 15th February. So we allowed 4 or 5 days for data consolidation, and then 2 days for analysis. Someone was asking how computationally intensive can this be? A day and a half of machine going through, and I can discuss the details later if you want, or you may interrupt me at any point, of course. I mean, this can be an interactive discussion, so feel free to raise your hand. Okay, so we published it later, but the important thing is that on early or mid-February, the results were already there. And actually, this was the first study to estimate effectiveness of the boosters against Omicron. And we have not been the first to many things, so I take this minute of glory. And these are our results. I leave the methods for the end. So these are our survivor curves in people with the booster and no booster. And we got that the booster dose was preventing half the infections during the Omicron period. And in that specific month, we had prevented 186 cases of Omicron infection per 10,000 vaccinated people in our population, which is a huge impact because, of course, it was a period of huge incidence. We were able to perform some subgroup analysis here, for example, depending on the time since the complete vaccination. So in those vaccinated more than 180 days ago, we had a slightly higher VE, but we had, so compared to the ones that had been more recently vaccinated, and the attributable risk, so the number of cases prevented was much higher. So because this population was at a higher risk at baseline. So let's go into the methods. I guess that's what you're here for. So we did a target trial specification. It's super simple. I think that target trial doesn't need to be complicated for simple questions like this. I think there are very complex questions. Xavi showed very difficult treatment strategies. This one's easy, it's booster, no booster. So this will be quite simple. So when we start thinking of what's the target trial that would answer our question, we have to be already thinking about what the data that we have to emulate it, so we cannot do this blank. Eligibility criteria will start reflecting the population that we're able to reflect with our data. So for example, for us, first criteria is to be residents in Spain, because we want to restrict to people that will have their vaccination and tests history well registered in our data. If we take any vaccinee, regardless if it's a resident or not, it's very likely that we're missing maybe previous vaccines or infections because it's someone that's eventually getting vaccinated in Spain. And we have also quite mobile population. So it's, this can happen. So that is a first restriction. We include that in our target trial. And then there will be the criteria that are associated to eligibility of the intervention we want to address. So for example, being 40 years or older, and this is because it's the group where the booster vaccination had already been recommended in Spain, had completed primary vaccination schedule with this definition at least 3 months before the start of follow-up in the study, and this will be disentangled later. With no additional vaccine doses in those 3 months since complete vaccination, and with no previous laboratory confirmed test. And this criteria was included first to not mess with hybrid immunity, because it's too complex, we don't want that. I think that's also, well, to avoid that, that people with previous tests have different propensity to get vaccinated, so that's a way to also forget about that source of confounding. And who do not make part of special populations with different vaccine recommendations or risk of infection. Also we restricted to people that had been vaccinated due to their age group. So if you were vaccinated ahead of your age group with the first dose, probably you're a healthcare worker, probably you have some comorbidity, so it's a way to restrict to general population. So in our target trial, we would go to defining the intervention, so people would be randomly assigned to receive an mRNA booster or not receive it, and we will follow people between 3rd January and 6th February, and our outcome of interest would be laboratory confirmed SARS-CoV-2 infection only. I know it's not the most relevant outcome measure, but it's the one that we had. So with this target trial, one of the main points is that it's very easy to articulate a causal question and then know what we're aiming to actually estimate with our observational study. So we're trying to measure the effect, and that's the total effect, I don't matter what's the mediators, total effect of receiving an mRNA vaccine booster dose in the prevention of documented infection with SARS-CoV-2 in a period of Omicron SARS-CoV-2 dominance. So very simple. Let's go to try to emulate this target trial. And for that, we had different data sources. We used the health card database. So we have universal health coverage, but it's not very updated. And this is why we could never use this to identify unvaccinated population, because we have lots of costs. So people that are in the health card database, because it's for free, no one unregisters from there. So we have people there that are actually not in Spain, so they would never appear in the vaccination or test registries. They would be unvaccinated, non-infected population forever. So we could not do any study with non-vaccinated population. But this is about people who actually got vaccinated. So we use this just to filter for residents in Spain. Then we have the vaccination registry, and that's daily updated and with national coverage. We have all SARS-CoV-2 laboratory tests registry, also nationally wide, even private laboratories is mandatory to report all the tests, and even some self-reported tests will be collected here, depending on the regions, some heterogeneity. And it's also daily updated. Of course, it's 2-3 days lag until everything's there, but it's quite good. And we had no data source for severe events or comorbidities, and that's the biggest limitations in our study, because we could not measure clinically relevant outcomes, and we could not adjust for any comorbidity. And surprisingly, the studies that did adjust found exactly the same result. So probably it's not that important when you're just virtually vaccinating the whole population. Let's go to specifying the components of our emulation of the Target Trial. Eligibility criteria, just the same as the Target Trial, and important. All criteria for eligibility need to be measured at baseline. This is before assigning the intervention, and this was clear in Xavi's presentation, and later I will talk about selection biases, and I hope this is even more clear by then. Intervention, receiving the booster. And the assignment is the more tricky, because actually this is the biggest difference between the randomized control trial and our observational study, is that the booster is not randomized, but of course with different probability across individuals. So we did the sequential randomization. So we did a series of randomized trials on each day when there was someone who was receiving a booster. So for each day between the beginning and the end of our study period, we identify, so every day we check the eligibility of the whole population cohort and classify them as having received or not the mRNA booster. So if you receive the mRNA booster on that day, you enter the trial on that day as an exposed person. And if you have not received the booster up to that date, you are eligible as control. And I will go to the matching processes in a bit. So yeah, this is not randomized. So we need to be accounting for baseline confounders, and we did that through matching, and we did exact matching. We looked at any factors that were potentially associated with the probability of receiving the booster and risk of infection. And this was limited by the data that we had, to be honest. We had sex, age. We broke that down into 5-year age groups, because the campaign moves very quickly through groups. There's a very high correlation in age, so that's a relevant factor in small groups. Postal code, to account for different circulation in different areas as well. Rollout of vaccines. The type of vaccine used for primary vaccination, so we were always matching people who had received the first, and it was very tricky, as it was mentioned before, because first we used AstraZeneca, then after the signal only in certain populations. I mean, it was very messy, this primary series, so we tried to adjust for that by matching on the type of vaccine. Then the week when the vaccination schedule was completed as well. And the number of tests in the beginning of the pandemic, negative tests only. And that was the only proxy we had for health-seeking behavior. This is the variables that we had. We did not have any comorbidity, and as I said, that was a big limitation. And we tried matching with and without replacement with similar results. Of course, without replacement, the sample size goes smaller and smaller, and because the matching, the exact matching is very exigent, of course you need a big sample size. So even if you have 47 million country, in the end you will end up with something like a 3 million sample. And in these matching processes, so every day we're matching on calendar. So we're implicitly matching by this calendar time that Xabi was mentioning, because of course the timing of vaccine administration does not match the circulation of the virus in red. So unvaccinated people have been living in a period where the circulation was lower. So by default they have lower risk of the outcome. So this method will implicitly match by calendar time as well. So how is this? I mean, Xabi already covered this, so forgive the repetition, but briefly. So we start on 3rd January with all our population, and basically those who fulfill eligibility criteria will start to be eligible as a control when the study starts, and will be eligible as control on every day until the end of the period. So actually, when you match with replacement, this same person can be matched as unvaccinated control to many different vaccinated people. They can appear multiple times in the database. If we only take them once, it doesn't change the result, it's just more imprecise. So this is someone that never received the booster, so you can select them as many times as needed. If they received the booster, they were eligible as controls in the period before the booster, and because this is with replacement, this can be also different times. But once they receive the booster, they will enter the target trial of that day. They start the booster, and only on that day. So among the vaccinated, there's no repeated individuals. You only have the repeated individuals in the unvaccinated controls. And so then we will have to look for a unvaccinated pair for that individual. And of course, they're only eligible as controls before the events or censoring, obviously. So now we move to the next thing. So was the start of follow-up of this trial. This matching makes this very easy. Person starts the follow-up at the time of matching. So every individual emulated RCT will start on the day of the matching, and we will measure the earliest among the outcome, which was laboratory confirmed infection, death, emigration, end of the study, or receipt of a booster by an individual in the non-booster group. As Xabi was saying, we apply the technique of concurrent censoring of the two. And this implies a per protocol analysis estimate, but because there was so many people receiving the boosters, the ITT did not make sense because there was so much violation in the assigned group at baseline. We use the cumulative incidence curves and compare the risk 7 or more days after the booster. And important here is that we will restrict the analysis to pairs that are both at follow-up on day 7. So we will drop every pair who at least one of the members experienced the event in the first 7 days, so that we ensure that on day 7 our matching is still valid. And we just put strapping for confidence intervals. So limitations, of course, like any observational analysis, we can have confounding if booster recipients and non-recipients have a different risk of infection or of diagnosis of infection. For example, if someone with a booster is feeling ill and not going anywhere to birthday party they drop out because they were feeling sick, the risk of infection can be lower than others. Or maybe someone is already feeling a bit sick or is a contact, so they defer vaccination because they're already suspecting something's going on. So many things can be going on. So to try to see this point, we compared the number of tests, negative tests, performed by individuals in the booster and the non-booster group from day 0. And here the vertical lines are day 7, because we will only measure VE after day 7. So we are taking this for VE estimation, and we're dropping the first 7 days after the booster. So what we see here is that there's actually a lot more testing in the non-booster group, but that lower testing is mostly happening in the first 7 days, while after day 7, the two groups are more comparable. So what we think is going on here is precisely what I was saying. So people who are feeling sick will not come to get vaccinated. Maybe they go to perform a test on the next day, or maybe they are isolated because they're contacts. They will not go to vaccinate, but they will receive a test. So we have this population here. But the fact that we don't observe such differences in the period where we will actually estimate the VE makes us more sure that this is not a relevant bias at that time. And we actually performed the exercise to estimate VE on each day of follow-up. And for that, we were always restricting to pairs that were both under follow-up at each point in time. So we were dropping every pair in which one of the two had experienced an event before. And when we see, so this is time 0 follow-up, we see that the VE is very overestimated on the first day after vaccine administration because, of course, the unvaccinated group is testing a lot, where you're getting positives. So the vaccine appears more protective than it is just because we selected people who were not symptomatic and did not have any risk contacts, for example. But this bias goes decreasing a bit in the first days until it crosses with some imaginary line I make in my head that comes like this. That is the mounting immunological response. So I see in my head this bias going down and the immune response going up, and it will stabilize around day 9 in the 50% VE that we observed overall. And interestingly, it's quite stable. I mean, it goes down a bit. It starts to be very imprecise because, of course, the number of people here is getting more and more scarce. But I think it was a useful exercise to see what was going on with our VE estimate in this period. So other limitations to finish. When we work with this data, it's difficult to have complete and updated data sources. I made the example of the healthcare database and why we could never identify and vaccinate individuals in Spain. Our registers may lack relevant data. I made the case of comorbidities. Maybe we have them, but they have not sufficient detail or they are incomplete. It's really difficult to account for differential case ascertainment and misclassification of the outcome according to vaccination if testing depends on vaccination status, and that's something we cannot know. Although the fact that there was not a lot of testing differences hopefully means this is not a huge problem in our results. Of course, this is observational, so it's very influenced by testing policies and practice. And actually, if we had continued this study, shortly after this, so in March, testing was interrupted. So if you look at the period in March, your estimates against infection go wild because, of course, testing policies is influencing who gets identified in your data. So we restricted the analysis also to a period where we hope that everyone that needed a test was getting it. So specifically for COVID, also we have the issue of previous infections after routine testing is what I was mentioning, but also we have asymptomatic infections, self-tests that never got reported. I mean, there's lots of unmeasured confounding regarding previous infection there. In this type of data, there's little concern about losses to follow up because we don't know, so we try to not look at it. We have the ghost problem, as I said. And then we're facing some ethical and legislative problems because most of these data, huge databases, much linked, whatever, were made available as a result of the COVID emergency. And we're seeing more and more countries withdrawing the legislative frameworks to have this type of data readily available for this type of studies. So we work also at the European level with the different countries in these types of studies, and there's some countries that cannot go forward because the permissions to access the data were withdrawn. So this is actually a real concern. So, yeah, thank you.
So, of course, everybody knows Elisa in this group, a very good member of VAC4U and crucial in doing the COVID study. And she will share with us her experience in doing that.
Thank you. I would really like to thank you and VAC4U for the invitation to present the result of our study today in such an outstanding course. I want also to thank everyone present or not who contributed to the making of this study. I'm going to talk about COVID vaccine effectiveness study. I have included the online QR for you to have the protocol and the report, the final report of the study. This is the disclaimer. Well, as you may probably know, in 2022, the the European Medicine Agency launched a call for an effectiveness and a study about the effectiveness of COVID vaccination in Southern, Central, and Eastern Europe after a previous call was won by the Nordic, a consortium in the Nordic country. So we won this one, and that have a special focus also on children and adolescents. This tender fall within the ECDC and EMA extended mandate to monitor the vaccine effectiveness and safety as part of the European Health Union package that was also yesterday mentioned by the colleagues of the EMA. Yes, that those mandates and the rules of the EMA was reinforced during the pandemic, so that was also a consequence of the, yes. We have some challenges in this project. First, we had a very tight deadline, as you might remember. We have signed the contract with the EMA in April 2022. We published the final study report 1 year later. However, we could take advantage of the European Pharmacoepidemiology and Pharmacovigilance and VAC4U research network that provided us the expertise and many tools for the conduction of the study, including a protocol template about the real-world effectiveness that Xavier and some colleagues wrote during the Access project, and we utilize as guide also for our study. Certainly, if we hadn't had those tools, we wouldn't have been able to carry out the study. Thank you. And well, we also have some challenges regarding the EMA requirement. In the call, different age population was mentioned, and for us it's referred to different research questions, and so different research, reference groups, whether to vaccinate or not to vaccinate, whether to use homologous or heterologous second doses, or to boost or not. We also, after the proposal acceptance, some changes were required in the core team, unfortunately, and we have also to change some, the secondary study objective that Fariba have proposed and Miriam about the methodology, and we have to change it. And also 2 of the data sources out of the 8 could not finally participate. This study, the context of this study was that COVID vaccine protection was replicated in the observational studies in the short term. That, of course, wane over time and also depend on the virus variant and also on the vaccine brand and type. In the countries, the heterologous vaccinations started to be applied, and even though the effectiveness of that mixed brand were not fully understood beyond the immunogenic clinical trials. Also, the Omicron started to be dominant in that moment and affecting more to the pediatric population with more severe cases, and limited real data information on children and adolescents was available in the European countries. So the objective of this study was to estimate the effectiveness and waning of immunity of Comirnaty, Spikevax, Vaxzevria as primary vaccination or booster doses in preventing different COVID-related outcomes. The primary objectives was to compare the heterologous versus homologous primary vaccination and the booster, meaning the third doses, in comparison with no booster in adults and adolescents. And also in children, we compared the effectiveness of primary vaccination in comparison with children without any vaccination. And we split the analysis by whether the people have had prior infection or not. Those primary objectives were stratified, as you may see here in the chart. Apart from the overall estimation, we estimated the effectiveness by type, by brand of the first and the third dose, by time after the vaccination, by some clinical subgroup that we were quite interested in, because these people is less represented or not at all represented in the clinical trials, by age category, variant of the virus dominant, and by prior COVID, according to the three outcomes that we included in the study. That about 33 estimates were calculated by 6 databases, by 2 primary schemes, whether homologous or heterologous, the same for the booster, whether homologous or heterologous, and for adults separated, adolescent and children aged 5 to 14 years old. Any information? So, because the EMA, well, the EMA asked to have a geographical area including southern countries, we included 2 databases from Italy, 2 databases from Spain, and also the Netherlands was represented by PharMO database, and the UK by CPRD. As outcomes, we include non-severe SARS-CoV-2 infection defined and a positive test recorded, or a diagnosis of COVID according to its database algorithm. We studied severe outcomes whenever the COVID was recorded as the cause of the hospital or intensive care admission, or whenever an admission was within 30 days of the COVID disease or positive test. Death with COVID was all the recorded death with COVID included and as the cause of death, or what not available in the databases. We assume that death which happened within 8 weeks of the COVID disease or positive test were due to COVID and were included in the analysis. So we designed a matched cohort study that ensured comparability by restriction, by maximizing matching. Also, some potential confounders were controlled by IP weighting and by stratification. The time zero that has been mentioned a lot, that is quite important, and in this case was the date when the second dose of the COVID vaccine was received, and that was used to compare homologous to heterologous schedules in adolescents and adults, and vaccinated in comparison with unvaccinated children. When the booster was analyzed, we used the date of the booster dose as the time zero for the analysis. And that date was also assigned to the control person. In this chart, you may see, well, the study population collected, including just people who baseline information of 2 years, and the full primary vaccination from which we started to study could be heterologous and homologous, as well as the booster doses could also be homologous and heterologous, and the children without vaccination were the control for the children with homologous vaccination. The matching criteria were quite similar to those that Susana has explained for her study. We matched first on calendar date of the second vaccination within that week. We also used the first vaccination date to matching. We match on the brand of the first dose, and also the year of birth, falling always into those age group that was used by the health institution to call to vaccinate, to people prioritize. We match by sex, region, and by clinical conditions, and by any COVID before time zero. When we analyze booster doses, we additionally match by on the date the booster was received by the boosted individual. Those matching criteria were paramount in this analysis, as my colleagues have already mentioned. The matching on vaccination date and region was crucial to control by calendar time, because that determined the virus epidemiology, the waves and its variants, and people given priority for vaccination. Also, the matching on birth year controlled by the age-related rollout of the campaign, and also by the risk of severe COVID, severe prognosis, and the vaccination options recommended by the public health institutions. So we started the follow-up the day after the matching date, meaning the time zero or booster time zero, till a COVID record was identified in the database. And additional to the current censoring date that we use in the study, we identify any extra dose of the vaccines, and that extra dose of the vaccine in any of both individuals in a pair imply the full pair censoring. And when the control receive a dose, her or his was started to contribute as vaccinated, and a new control for her or him was selected to keep the intention to treat analysis. As regards the statistical analysis, we were interested also in absolute impact. So we estimated the incidence rate and the incidence rate differences between the compare group. We computed, we created IP weighting Kaplan-Meier curves, IP weighting Cox model to estimate hazard ratio, and with that hazard ratio, we estimated vaccine effectiveness by 1 minus the hazard ratio multiplied by 100. And for the IP weighting, we use potential confounders, including the matching variables and other co-medications and comorbidity, as well as test and visit to the health system up to 2 years before the time zero whenever it was available. It was not always available. We also collected information from the 7 days before the time zero, the matching date, to control by healthy vaccinee effect, because as it was already mentioned, that by default the vaccinated people go to receive the vaccine because they feel healthy enough to do so, while the control could not be in that healthy situation. And that is key to control the comparison in children, because we compare vaccinated against no vaccination, and in boosted against, in comparison with unboosted people. We finally ran a sensitivity analysis restricting to pairs with a negative test before comparison moment in order to control the effect of the differential access and testing between the individuals in the group. For subgroup reaching reduced sample size, such as the clinical subgroups, or those who have rare outcome, like in the children, we perform random effect meta-analysis. Yes, just to mention that, yes, the restriction to pairs in which at least one of the two individuals the both individuals have to have at least one test before, reduce the sample size, and that is that impact normally the result. In the result, I will give some examples because there are many information in the project, so I will just present some. We identify in all the databases about 20 million people fully vaccinated. Most of them receive an homologous primary vaccination. Of them, less than 2% were able to be matched to an heterologous primary vaccination. And we got around about 89,000 individuals for the primary heterologous versus homologous comparison. For the children and the boosted individuals, we could match more above 91% of individuals. So we got a very powerful sample for the booster analysis of 5.6 million people. We got less for the adolescent because they received the booster later, and we have the stop. The end of the study period. This is the table with a summary of the vaccine effectiveness in the different groups, and according to the 3 outcomes we studied. For the effectiveness of the homologous was observed lower than the heterologous in the primary vaccination, although there were also 2 databases in which no differences were observed among them. No differences were observed against the severe COVID in homologous versus heterologous primary vaccinations. For the children, we observe a broad range or effectiveness between 29 to 77% of protection against non-severe infection during Omicron, so it was quite broad between the databases, and that protection was reduced Later during Omicron, as we expected already, till 42%, and also even an increased risk among the vaccinated children was observed. We had seen that the vaccination in children prevented about 71%. I mean, the effectiveness was about 61% during Delta, and was also reduced to 50% no significant effectiveness during Omicron period. The boosted provided quite high protection, whether homologous or heterologous, against severe COVID and death with COVID. And many cohorts, as you see here, and especially also in the individual databases, were not sufficient, did not have sufficient sample size or follow-up time to answer all the questions. Regarding the attributable benefit from booster doses of a special population that we believe it quite relevant for decision making, we observed that among the elderly, the booster vaccination reduced between 4 and 6 hospitalizations and between 3 and 7 deaths with COVID per 100,000 persons boosted per day. Among the individuals with immunodeficiency, the booster reduced 3 to 4 hospitalizations and between 1 and 2 deaths with COVID per 100,000 vaccinated per day. Regarding the meta-analysis in clinical subgroup, you may see here the protection against hospitalization with COVID for people with cancer, immunodeficiency, general severe renal disease, with homologous booster and with heterologous booster. The vaccine effectiveness was above 54% in 2 or 3 databases participating and with information in those groups. And regarding the death with COVID, the protection was above 73%. Also in children, we were able to identify around 40,000 individuals with any immunodeficiency or treatment, immunosuppressant treatment. We estimated that the primary vaccination prevented 2.5 cases per million children vaccinated per day. The duration was estimated for all the intervention we studied, and for that, as Susana has already mentioned, just the pair still at risk at the beginning of every time window were analyzed. This is the example of the duration of the booster effectiveness. As you may see, this is for hospitalization with homologous booster, with heterologous booster, and this is death with COVID, the effectiveness with homologous booster and with heterologous booster. And we observed that the effectiveness lasted till the first month, because some databases could only provide short follow-up time, but it's reached 5, the effectiveness was observed up to 5 months in databases with available follow-up. I wanted also to mention the increased effectiveness immediately after the vaccination, as Susana showed. We thing, we also had here the detection bias because of the vaccinated people have less probability to be tested immediately after the vaccination. So was that attributed benefit entirely attributed, to the vaccination? Was that the effectiveness that we found did still have any confounding insensitivity analysis restricting to pairs that have any testing before? We observed that the vaccine effectiveness didn't change much. So that can be correcting the confusion by a measured confounder of the seeking behavior or, yeah. A secondary analysis I didn't mention before, I think I lost the slide. We also studied the effectiveness against total mortality, any cause of death, of the booster dose. And we observed a range on effectiveness that was similar to the one that we observed against death with COVID. Yes, we understand that here there are many uncertainty in this analysis, and that it could be that some confounders, the confounders that affect this analysis be different than those that affect the COVID, the analysis of COVID with death. As conclusion, well, real-world evidence shows that the primary vaccination in children and booster doses give additional protection against both hospitalization and death with COVID in clinical subgroup of vulnerable people, the elderly, and also in the general population. The effectiveness was observed higher but shorter in duration in heterologous than homologous booster in comparison with the unboosted pairs. They were not completely, nor directly comparable among them. Primary or secondary care data sources are paramount to study a special population that are not represented in clinical trials and may not be detectable in other records without that information. Also important action, we believe, are needed to speed up the update and availability of data to research near real-time monitoring using observational studies. Confounder or bias are suggested by the effectiveness we observed against any cause mortality. And by other hand, the effectiveness estimation were not confounded but by covariates according to, this is an example, we observed the crude hazard ratio and the adjusted hazard ratio were not that different. So in this context of quite exigent matching process, and in the scenario of the pandemic in which many people get the vaccine regardless their condition, few confounders may be playing a role apart from those used in the matching. Misclassification of the hospitalization with death or death with COVID instead of for COVID would underestimate the effectiveness. Misclassification of immunodeficiency would overestimate the effectiveness because we were including general population. And the potential effect of the lower testing immediately after the vaccination may overestimate the effectiveness, and that I was questioning whether that could be corrected or solved by time-varying confounding analysis. and some limitation of regarding the limited sample size, a follow-up time we had in many of the strata, or in some of the strata, such can be those of children aged 5 to 11, or clinical subgroup, or follow-up time during Omicron period. I have not showed any result for prior COVID because the lack, we could not match, or we did not finally match by the time the prior COVID, by the moment the individuals had the prior COVID. So we think that that limited the interpretation. And well, finally, the number of prior negative tests and contact with the health system were not available in all the databases. That is helpful for the control of unmeasured confounder. Well, in this study, we have applied our expertise in safety study to perform effectiveness studies that was new for many of us. So we have now that experience. Also, task force of programmers has been created. For example, the metadata using COVID, the code list that we have in Back4You were used, I mean, the bridge method were used to create variable definition, and now it had been used by for the other projects. And also the matching performance was very hard as technical challenge, but we did it. Yes, we think that real-time monitoring of the databases instances could improve the study plans and to have a precise sample size estimations. We have just been received that this paper had been accepted for publication in Vaccine. Congratulations to all the consortium. We also had an oral presentation in Porto and a poster presentation in Glasgow. And we are now working on a draft manuscript about children and adolescents. And yes, thank you very much. And yes, I could